We have a highly specific, very critical mission for you on today's deep dive. We are dissecting a notoriously lethal cardiovascular event known as an intracerebral hemorrhage, or ICH.
Right, and it's a topic that honestly doesn't get enough attention,
Yeah,
despite how severe it is.
exactly. So to do this, we're pulling from a really massive stack of recent stroke registries, um, large-scale epidemiological data sets, and some highly detailed neurological case files.
And case files are what really ground the data, I think.
Yeah, they really do. And to put you, the listener, right in the center of why this specific slice of medical data matters, I want to pull one scenario straight from those files.
Oh, the 74-year-old woman, right?
Yes, that one. So, you have a 74-year-old woman. She's found slumped at her kitchen table by a neighbor. She is completely aphasic, meaning she can't speak, and her entire right side exhibits hemiparesis.
Which is that limb weakness, right?
Yeah, exactly. But the very last thing she can clearly recall is a sudden, blindingly severe headache.
And see, that terminal detail right there, the sudden severe headache, that is the clinical differentiator. It separates this from the vast majority of stroke presentations.
Because most people think of a stroke as, a blockage.
Right, exactly. When we look at standard ischemic events, the pathology is an occlusion, like a clot. The tissue downstream basically starves. But a hyperacute headache of that magnitude points away from occlusion and, well, directly toward a rupture.
Meaning the pipe actually broke.
Yeah, a vessel within the cerebral parenchyma has physically burst. Blood is actively pooling directly into the brain tissue under incredibly high arterial pressure.
Okay, let's unpack this, because understanding the sheer scale of that pathology is totally crucial. Looking at the broader stroke registry data in our stack, ICH is a distinct minority of the total volume, isn't it?
It is, yeah. It hovers around 10 to 20% of all stroke incidents.
Right. Yet when you look at the mortality columns, it punches far, far above its weight class. I mean, the 30-day mortality rate is sitting dangerously close to 50%.
It's staggering. The clinical weight is wildly disproportionate, and that really comes down to the destructive mechanics of the bleed itself.
Because it's not just starving the brain of oxygen anymore.
Exactly. Unlike an ischemic stroke, where the primary damage is just tissue dying from lack of oxygen, an intracerebral hemorrhage introduces mechanical trauma.
Oh, wow. Mechanical trauma from the blood itself.
Yes, you have a rapidly expanding hematoma inside a rigid, closed box, which is your skull. That creates severe mass effect, increasing intracranial pressure, and literally physically crushing adjacent brain structures.
That is terrifying.
It gets worse, actually.
Yeah.
On top of that, the breakdown products of the blood itself are highly toxic to the surrounding neural tissue. It triggers this massive secondary inflammatory cascade.
So half of the patients do not survive past a month because of that dual-pronged mechanical and chemical trauma.
Sadly, yes.
And that sobering reality is exactly why you, listening right now, need to care about the mechanisms we're exploring today. Because we're not looking at a random, unpredictable lightning strike here.
No, not at all. The epidemiological data frames this as a mechanical failure of the human vasculature.
Right, it is predictable. And it's heavily influenced by chronic physiological variables that are, deeply tied to our daily habits.
Yeah, the structural integrity of a cerebral blood vessel does not just fail overnight. It degrades over years, perhaps even decades.
Which means we have time to catch it.
Exactly. Because it's a cumulative process, there's a substantial identifiable window for clinical intervention long before the rupture actually occurs.
But reading through the 30-year longitudinal data, I ran into this massive contradiction regarding that intervention window.
You mean the incidence rates?
Yeah, I mean, if the mortality rate is 50%, the natural assumption is that modern cardiovascular medicine is doing absolutely everything possible to drive those numbers down.
You would think so, right?
Yeah. And over the last 3 decades, the pharmaceutical protocols, the clinical protocols for managing hypertension have improved exponentially. Yet the overall incidence rate for ICH hasn't budged.
Nope. It has remained essentially flat.
Wait, if hypertension is the main cause and we're treating hypertension better, the numbers have to go down. It's like we're bailing water out of a sinking boat faster than ever, but the water level inside the hull isn't dropping even a millimeter. What is the new leak here?
If we connect this to the bigger picture, we find that the flat trend line is actually kind of an illusion. It's hiding shifting etiologies.
What do you mean by shifting?
Well, the contribution of unmanaged hypertension to the overall incidence of these strokes has genuinely declined. We are successfully bailing that specific water out of the boat.
Okay, that's good news at least.
It is, but two entirely different mechanisms of vascular failure have surged proportionally to fill the exact void left by better blood pressure management.
Okay, I did notice the surge in anticoagulant usage in the registry data, which, makes statistical sense given our aging demographic.
Right, exactly. More patients are surviving things like atrial fibrillation and deep vein thrombosis.
So more patients are on long-term systemic blood thinners. I mean, you solve the clotting risk, but you inherently increase the bleeding risk.
Exactly. The anticoagulant usage is a really significant factor. But the secondary, highly insidious driver creeping up in the data is cerebral amyloid angiopathy, or CAA.
CAA. Okay, what exactly is happening in the brain with that?
So this is a pathology where amyloid beta peptides progressively deposit into the middle and outer layers of the small and medium-sized arteries in the brain.
Amyloid, that's the same protein associated with Alzheimer's, right?
Yes, exactly the same protein. As those amyloid proteins accumulate, they actually replace the normal smooth muscle cells in the vessel wall.
So the pipes are literally changing their physical structure.
Yeah, the vessels lose their elasticity, they become highly rigid, kind of tortuous, and incredibly prone to micro-cracking and eventual rupture, completely independent of systemic blood pressure spikes.
Wow. So the shifting etiology of these bleeds directly alters the clinical profile of the patients walking through emergency room doors.
It radically alters who is in the crosshairs, yes.
Because the data highlights very distinct, disparate populations getting caught up in this, we are seeing a heavy impact on young and middle-aged Black and Hispanic populations, right?
Yes, occurring at much higher frequencies than in white cohorts of the exact same age.
And we also see disproportionate clustering in medically indigent populations who just lack systemic access to consistent blood pressure treatment.
Right. And simultaneously, you have that surge in the elderly population dealing with CAA and the blood thinners we just talked about.
It's like a perfect storm.
It really is. We are looking at a collision of socioeconomic determinants of health, an aging population, and iatrogenic risks, which are risks from other necessary medical treatments.
So the systemic lack of access to early aggressive blood pressure management creates an environment where that vascular degradation just accelerates unchecked in younger, disadvantaged populations.
That's excellent.
But here's where it gets really interesting. The data sets don't just point to age and socioeconomic factors. There's a deep genetic thread woven through all this.
Ah, yes, the APOE gene.
Yeah, the apolipoprotein E gene. We are looking at the APOE epsilon 2 and epsilon 4 alleles playing a massive role here.
Right, particularly in lobar hemorrhages, which are the bleeds that occur closer to the surface of the brain.
So how do those genetics actually change the vessel?
Well, the genetics provide the physiological blueprint for vascular vulnerability. Those specific APOE alleles dictate how the brain handles lipid metabolism and, crucially, how it clears out those amyloid beta proteins we discussed with CAA.
So it's tied directly back to the amyloid buildup.
Exactly. The epsilon 4 allele aggressively enhances the deposition of amyloid into the arterial walls.
And the epsilon 2 allele.
The epsilon 2 allele is fascinating. While it's actually somewhat protective against Alzheimer's disease, it paradoxically promotes extreme friability-like brittleness in those same cerebral vessels once the amyloid is present.
So the genetic variants are actively remodeling the microscopic architecture of the artery. They're basically turning a robust pipe into brittle glass.
That's a perfect way to describe it.
But if genetics and age are loading the dice and making the vessels brittle, what is actually rolling them? I mean, it brings us right back to blood pressure, doesn't it?
Oh, absolutely. Even with amyloid buildup and blood thinners altering the landscape, hypertension is still the dominant, undisputed heavy hitter.
Yeah, flipping through the clinical profiles in these case studies, the convergence of evidence is just overwhelming.
It really is. Depending on the specific registry you look at, between 72 and 81% of all ICH patients present with a documented history of hypertension.
It's huge.
Right. It remains the primary mechanical driver. The structural fragility from CAA or the bleeding propensity from anticoagulants, they simply lower the threshold at which hypertension can cause a rupture.
But the elevated pressure is almost always the catalyst.
Yes. And we see this confirmed structurally upon admission. A massive proportion of these patients exhibit left ventricular hypertrophy.
Meaning the heart muscle is actually thickened.
Exactly. The myocardium has physically remodeled and thickened because the heart has been pumping against chronic, extreme, systemic vascular resistance for, a decade or more.
Right. So the left ventricular hypertrophy is the chronic footprint. But the detail in these case studies that genuinely stopped me in my tracks was the acute timeline of the blood pressure right before the structural failure.
The monitoring data is incredible, isn't it?
It is. We have this persistent, intuitive assumption that a vessel bursts because someone gets angry, their blood pressure spikes for like 5 seconds, and boom, a vessel pops.
Like in the movies.
Exactly, like in the movies. But the continuous monitoring data shows that means systolic blood pressure actually begins a steep, aggressive climb in the day, literally the days leading up to the actual ICH event.
Yeah, the physiological environment deteriorates well before the physical rupture. It points to a failure of the body's homeostatic autoregulation.
So the body's natural buffering system just breaks down.
Right. The baroreceptors and the autonomic nervous system, which usually buffer these fluctuations, they begin to fail under the chronic strain. The sympathetic tone ramps up, and the pressure starts mounting uncontrollably.
So this isn't a sudden lightning strike out of a clear blue sky. This is a rising tide.
Rising tide, yes.
It's like the water is pushing harder and harder against a compromised dam for consecutive days until it finally breaches the wall.
A rising tide of unchecked hydrostatic force pushing against a degraded physical barrier.
Taking that mechanical analogy of the dam breaching, what is physically happening to the wall, the blood vessel, to make it give way?
Well, the primary pathological process occurring deep in the brain is called lipohyalinosis.
Okay, break that down for us.
So we are talking specifically about the small penetrating arteries,
Right.
like the lenticulostriate arteries that branch off the middle cerebral artery at these really harsh right angles.
So they're taking a lot of direct force.
Exactly. Under the relentless sheer stress of chronic hypertension, plasma proteins are literally forced into the vessel wall. You get fibrinoid necrosis. Macrophages infiltrate the space and turn into foam cells.
And the muscle cells in the wall die, right?
Yes, the smooth muscle cells die and are replaced by collagen and this hyaline material.
So to be clear, in previous deep dives, we talked about ischemic strokes, where arteries get clogged like a blocked pipe from the inside out.
Right, atherosclerosis.
But this is completely different. It's the same organ, the same vascular tree, but this is a structural failure from the inside of the wall itself. The pipe itself is bursting.
It creates a thickened, yet structurally incompetent vessel. It loses its ability to dilate or constrict. It just becomes rigid.
And then it balloons out.
Yeah. Secondary to that lipohyalinosis, you see the development of Charcot-Bouchard microaneurysms. These are microscopic balloon-like outpouchings that form at the very weakest points of these hyalinized vessels.
So the high-pressure blood swirls into those tiny pockets, creates intense wall stress, and then boom, catastrophic blowout.
What's fascinating here is how purely mechanical that primary cause is when you strip away the background noise.
You're talking about that one epidemiological study, right?
Yes. They went to great length to isolate the primary ICH bleeds. They scrubbed the data, systematically excluding patients with underlying tumors, removing those with arteriovenous malformations.
They pulled out cocaine-induced spikes, anyone on blood thinners.
Right. They isolated the pure, unadulterated structural failures. And chronic hypertension alone explains 72% of those primary bleeds.
72% of these catastrophic failures trace back to a single, measurable, and highly modifiable metric of vascular physics. That is wild.
It really highlights how much control we actually have.
So what does this all mean for you, the listener? If the physical bursting of the vessel is driven by sheer pressure, the immediate question is how much of that pressure is within our control?
And the answer is quite a lot.
Looking at the global population attributable risk data for ICH, we are presented with a web of overlapping lifestyle variables that account for a staggering 87% of the global risk.
87%. Let that sink in.
87% of this pathology is tied to factors we can physically alter. Let's break down that list.
The stratification provides a very clear roadmap. Hypertension sits at the absolute top, driving 56% of the risk.
The strongest single risk factor.
By far. But right behind it is a sedentary lifestyle, contributing 35%. Poor dietary habits account for 25%. Psychosocial stress also drives 25%.
Right, let me stop you there. Central obesity is 13%, current alcohol intake is 10%, and smoking is 4%. But looking at those numbers, 56, 35, 25, 25, they add up to well over 100%.
They do, and that's because we're looking at a compounding physiological cascade, not just isolated variables. They overlap.
Oh, I see. So having one makes the other worse.
Exactly. The overlap is where the pathology accelerates. A sedentary lifestyle inherently drives central adiposity, or belly fat.
Which isn't just inert weight.
Right. Central obesity acts as an active endocrine organ. It pumps out pro-inflammatory cytokines, which literally damages the endothelial lining of your vessels.
And that systemic inflammation drives up insulin resistance and sympathetic nervous system activity.
Which ties directly into your psychosocial stress metric. When chronic stress keeps your HPA axis, your hypothalamic pituitary adrenal axis, constantly activated, you have this relentless drip of cortisol and adrenaline.
So your blood vessels are basically locked in a state of vasoconstriction.
Exactly. Add high alcohol intake to that, which further stimulates the sympathetic nervous system and impairs the reflexes that naturally lower your blood pressure.
It is a massive interconnected metabolic syndrome.
The poor diet, the lack of physical movement, the chronic cortisol, they all funnel directly into sustained hypertension.
And the hypertension then physically remodels those deep arteries through lipohyalunosis, creating the microaneurysms that eventually rupture.
You've got it. That's the entire cascade.
But pointing out this overlap to the listener, this is incredibly empowering. This isn't just some random tragedy or an unavoidable genetic destiny lurking in the shadows.
Not at all. That 87% represents a monumental opportunity for prevention.
Exactly.
Yeah.
Managing psychosocial stress, dialing back the sympathetic nervous system with daily movement, optimizing your diet to reduce systemic inflammation, these are not just abstract wellness concepts.
No, they are literal physical interventions. They are aimed at preserving the elasticity of the penetrating arteries deep in your brain.
You are quite literally fortifying the structural integrity of the dam.
And the clinical neurology community treats that structural maintenance with absolute severity, particularly if a patient survives an initial intracerebral hemorrhage.
The secondary prevention targets are strict, right?
Fiercely aggressive. The long-term secondary prevention target is definitively set below 130/80.
Below 130/80. That is notably lower than the targets we usually see for ischemic strokes.
It is. And that strict threshold reflects the brutal, unforgiving nature of the mechanical failure we've been dissecting.
Because once a vessel has popped, you know the rest of the pipes are bad.
Exactly. Once a vessel has demonstrated structural incompetence by rupturing, you have definitive proof that the entire vascular tree has been compromised by that lipohyalunosis.
So you cannot allow the hydrostatic pressure to climb anywhere near the danger zone again.
Right, because the remaining vessels are already sitting right at their breaking point.
Which circles us all the way back to the case file we opened with. The 74-year-old woman found fully aphasic at her kitchen table.
According to the clinical notes from the paramedics, she had long-standing, poorly controlled hypertension.
Significant central obesity and a largely sedentary lifestyle. No history of recreational drug use, no anticoagulant therapy, no underlying malformations.
He fits the exact demographic profile of everything we've discussed today. A textbook presentation of the primary pathology.
Decades of unmanaged systemic resistance driving lipohyalunosis, quietly remodeling those arterial walls until a microaneurysm finally gave way under the stress.
A catastrophic mechanical failure that was fundamentally preventable.
So, we have navigated the raw mortality statistics, the complex shifting etiologies, the microscopic reality of fibrinoid necrosis, and the immense power of modifying our daily risks.
This raises an important question, though, based on that days leading up data we talked about earlier.
Oh, about the blood pressure climbing before the stroke.
Yeah. If the autonomic nervous system begins to fail, and means systolic pressure climbs aggressively in the specific days preceding a rupture, are we entering an era where wearable technology could act as an early warning system?
Wait, really? Like a smartwatch?
Think about it. Could the continuous blood pressure sensors currently being integrated into commercial smartwatches detect that specific rising tide signature?
Oh, wow. So your watch could literally buzz on a Tuesday to warn you to go to the hospital before the vessel in your brain actually bursts on Thursday.
It's entirely possible based on the physiological data we're seeing.
That is a wild thought to end on. Well, we're going to wrap up our analysis of the case files right here. I highly encourage you, as you digest the mechanics of everything we just covered, to go take the long, brisk walk.
Absolutely.
Actively knock down that sedentary risk factor, lower your sympathetic tone, and practice some of that preventative structural maintenance on your own vessels. We will catch you on the next deep dive.